Welcome to our In Focus discussion on COVID-19 disparities in Black communities. Over the last 18 months of the pandemic, we've seen the virus disproportionately impact communities of color. Race and ethnic groups, such as the Black and African American communities, show lower vaccination rates than others. So tonight we explore why that is and what can be done to help bring those numbers up. Joining us tonight are Dr. Richard Ferguson, who is the president of Black Physicians of Utah and Chief Medical Officer of Health Choice Utah, and Dr. Samuel Cheshire, Associate Professor of Pediatric Neurosurgery at the Huntsman Cancer Institute. Thank you both for being a part of our conversation tonight. We will start with you, Dr. Cheshire. What has the Black and African American experience been like during the pandemic, and what are some similarities and differences to the white population?
Well, thank you for inviting me here tonight. So I think the Black experience with the COVID pandemic has been very similar to everybody else's. It's been a huge inconvenience and a direct impact to a lot of people's health of themselves and of their loved ones. But as you know, that Black people are disproportionately represented in frontline jobs, service industries, and things of that nature. So their rates of having COVID and suffering from it are disproportionately larger. That combined with the poor overall medical care that African Americans have in this country has led to worse outcomes in the African American and Black communities.
Well, Dr. Ferguson, how did someone's occupation or profession determine the kind of experience that they had during the COVID-19 pandemic?
Well, I think definitely we've seen when there was a significant loss of jobs that the African American community was disproportionately affected because, one, as Dr. Cheshire said, being frontline, but also part of that often working class and not many having the ability to be remote. So some of us are privileged with that ability, especially when it looks at tech jobs within the state, but others did not have that. Some were servers, some are folks that are even cleaning, particularly in schools, or just part of sanitation, keeping our areas clean and safe, are often put at more risk for becoming infected. So sometimes they either got sick while on the job or said, I'm not going to risk becoming sick. So that led to further isolation and often more depression for the Black community.
I also like to add that having to go to work as opposed to working at home during the pandemic added a significant amount of stress thinking about being exposed to the virus and contracting the virus and giving it to your family members at home. I think that's why the levels of depression and mental health problems were greatly increased in this community.
All right, so let's turn now to the data on vaccinations. Dr. Ferguson, what do we know about people getting the COVID-19 vaccine when we break it down by race and ethnicity?
So right now we know that based just in Utah, or actually we can go, because nationally right now, based on I think the numbers from at least September 24th. So I think you can see here, this is from CDC data. But much of that, some of the CDC data is reported, of course, by by Utah hospital systems. But we can see that there's, I would say, less disparity when you look at it when we're going by age group. So when you're 65 and older, we can actually see there's increased compliance and less hesitancy, less resistance with getting the vaccine. When we're actually going to those under the age of 45, 18 or 45, that's where we're actually seeing more hesitancy, more resistance to getting the vaccine. Now, why is that? Well, I think we can understand that there's a difference for their reasons for wanting or not wanting to get the vaccine yet. And part of that, for at least the Black community, distrust of the healthcare system, mistrust, misinformation, often spreading faster than fact. And thirdly, there has been a systemic racism within medicine for some time that has disproportionately affected health outcomes for African Americans.
Okay, and that's what we're actually going to dive into next on our next segment. So Dr. Ferguson and Dr. Cheshire, hold that thought. We do have to take a quick commercial break, but when we return, we'll resume our In Focus discussion on COVID-19 disparities in Black communities. Thanks for staying with us for our second In Focus discussion tonight on COVID-19 disparities in Black communities. We pick up our conversation now with Dr. Richard Ferguson, who is the president of Black Physicians of Utah and chief medical officer for Health Choice Utah, and Dr. Samuel Cheshire, associate professor of pediatric neurosurgery at the University of Utah School of Medicine. So, Dr. Cheshire, we will start with you in this conversation. Why is there so much vaccine hesitancy among the Black and African American population?
Well, the first thing I want to point out is that vaccine hesitancy and resistance in the African American and Black population is no different than it is in the white population. In fact, there's several studies that show that it's actually slightly lower in the African American population than the overall population and then the white population. Therefore, there isn't an increased amount of hesitancy or resistance in the population. But that being said, the reasons for the hesitancy are different. In a sense that it's less political and it more has to do with mistrust in the medical system and as well as misinformation is a big problem in the African community, as well as all the communities out there who are hesitant to obtaining the vaccinations.
Dr. Ferguson, let's hear from you. We see a couple of these reasons up on the screen here, some that you and I have talked about. Can you elaborate a little bit on some of the points that we see here on the screen?
Yeah, I think one thing that addresses vaccine hesitancy is some people earlier on, and we're talking first and second quarter of this year, I don't trust. It came around very quickly, and I'm concerned about long-term side effects. What can you tell me about that? And doctors such as myself, Dr. Cheshire, myself, and others within Intermountain and the University of Utah Health System have been on these front lines doing as much outreach as we can to address and dispel many of these myths. But it seems sometimes, unless it's a community leader or a loved one, that makes the difference. So sometimes all it takes is just contacting, getting to that grandma or that maternal figure within the family or a particular church leader or someone that is most trusted, and that could be within a university, within a school, within one's place of work. All it takes is sometimes that person to say, I care about you, you should get this. Make an effort to protect those that you love, not just your own health, but for those that you love, because that's really what this vaccine can really do. Not only does it reduce the ability to infect others, but it creates that sort of circle of immunity, protect those that aren't able to get the shot. And there's quite a few in Utah that, because of our young state, that aren't available to get it yet.
Let's also talk about the small Black population that we have in the state, as well as this wait and see approach. What exactly does that mean?
So there's only about 47,000 African Americans in the state of Utah. So the small population creates an effect where you don't actually see the effects of COVID in your own community because they're so dispersed out. I think another important point to make about the African American population in Utah is they're actually on average 7 years younger than the white population. And as you know, the young people are the most hesitant in obtaining vaccinations across all racial groups. So I think the combination of a young African American population with very few of them allows you to wait and see, because it's not personally affecting you directly. It's not you're most likely gonna not go to the hospital. You're most likely gonna have a moderate infection.
But just to add on to that, sorry to interrupt, is two things are happening right now with that particular population. More are feeling increased societal pressure to get it because they're like, well, my peers are getting it now. And because of Delta is more infectious, putting more young people, those under the age of 30 into the hospital, those under the age of 18 are getting hospitalized, getting into the ICUs from COVID infection. And they're saying, well, maybe it's time for me to get it now that I'm seeing more, as they often want to refer to, hype in the news. This maybe is a good decision and there's much more benefit than risk. And I think that's really starting to reach home. And the second thing that's going to help are the mandates. People are going to want to increase access to public places, social spaces, and the mandate is going to increase that not only for employers, but also for people that want to eventually fly on a plane, people that want to go to a concert. I think possibly the Jazz may eventually have that required of fans. This is going to be coming more in the future, and that's how we're going to get more compliance and to protect more people.
Yeah, it's interesting that you say that, because this month, as after the mandates came out, the proportion of African Americans who are actually getting immunized finally reflected the proportion of African Americans in the population. So the mandates certainly work.
Yep.
That is good to hear. Dr. Cheshire, how does historical exploitation of African Americans in medical trials and experiments play a role in how African Americans view the COVID-19 vaccine?
I think your question directly touches towards the Tuskegee experiments, which a recent study demonstrated about 80% of African Americans have knowledge of the Tuskegee experiment. It was a 40-year-long experiment that started in 1932, where the U.S. Department of Health actually recruited African American men in Tuskegee, Alabama, and they told them that we'll treat you for syphilis and we'll give you free health care, and they never treated them. They lied to them and gave them placebos, and they watched the natural course of the disease over 4 decades. And they watched them give it to their family members. They watched the secondary disease processes of heart diseases, renal diseases from the chronic syphilis occur in these males without ever telling them they were in a study and without ever treating them. So when it finally came out in the early 70s, it was a very big deal. In the medical community, it certainly changed the way that we do research and the regulations behind them. But it has created a great sense of mistrust in the African American community to this day. There's this good study out of University of Tennessee that showed that a huge portion of the reduced life expectancies in African American males is directly attributable to knowledge of the Tuskegee study and just not wanting to participate in clinical trials and not wanting to go to the doctors, because there's such a sense of mistrust. So you often hear African Americans, and I often hear them talking about, I don't want to be experimented on. I'm not going to be anybody's lab rat. And I think that's probably, that sentiment is in all ethnic communities, but it most likely represents a higher proportion in the African American community because of the Tuskegee trial.
Yeah, there's a lot of trauma there. I think people need to understand that when we're talking about these historical trials, we're talking about decades, right, of historical trauma, and that's where the mistrust comes from. Great conversation there, Dr. Ferguson and Dr. Cheshire. Stay with us. We have to take another quick commercial break, but when we return, we'll resume our In Focus discussion on COVID-19 disparities in Black communities. Welcome to our third and final In Focus discussion tonight on COVID-19 disparities in Black communities. Before the break, we were joined by Dr. Richard Ferguson, who is the president of Black Physicians of Utah and Chief Medical Officer of Health Choice Utah, and Dr. Samuel Cheshire, Associate Professor of Pediatric Neurosurgery at the University of Utah School of Medicine. We pick up now right where we left off. We'll start with you this time, Dr. Ferguson. Now that we've talked about the what and the why, let's talk about the how, as in solutions. What are some ways that we can increase the vaccination rates in our African American and Black communities?
I think part of it will start with particular efforts like we're doing right now, making sure that people understand there are trusted voices in the community. Dr. Cheshire and I represent that. Black Physicians of Utah represents that. University of Utah represents that. Intermountain represents that. Please don't chase the Facebook meme. Trust your healthcare providers. Trust your church leader if they are supportive of the vaccine. They want what's best for you. So I think that's where it ropes into one part of the solution is bringing in community leaders to help us on this effort to really reach out to people. Second, mobile vaccinations. Go to where people live that are less likely to get vaccinated or don't have as many options. And also make scheduling easier. The problem that has occurred in Utah with people calling into the county initially in March and April, that's often discouraging for many people. And they say, well, if I can't get an appointment between 8 and 5, and I have to go home, take care of my kids, put my kids to bed, or I have to take care of my family, and everything shuts down at 6, or there's no vaccine availability on a Saturday and a Sunday, you've got now another week that person's at risk when they really wanted to get it. They actually believe the information, they believe the facts, they believe it can protect them, but the system doesn't make it easy for them to access the vaccine. So let's address that. Make it available for outside of business hours. And then once again, larger community partners. Once again, the Utes, in regards to they could associate and have a mobile vaccine right outside of these football games for the rest of the season. That would really help. Also having a mobile vaccination site in front of a Jazz game. And then I think third is making sure that people feel comfortable sharing their medical information when they're doing their intake questions to be able to receive the vaccine. And then lastly, I would say, make sure that people understand it's free. So when it's misleading, when often part of these questions online and on the phone, they ask you what your insurance is, which isn't necessary for you to get the vaccine. And that's what throws people off, and they think, well, I don't have insurance, or I don't have a card, maybe I can't get access. We really need to discourage that. Even when we have messaging, we have to get on the same page with messaging, and that it's free to access the vaccine.
So there are people out there, right, Dr. Shashir, that think that they have to pay for this vaccine?
Absolutely, and I think what Dr. Ferguson said earlier about having the messaging be consistent. I actually went myself on the Department of Public Health, Utah Department of Public Health's website, and it clearly stated that it was free. But when I clicked on the link to schedule an appointment, it said, the first thing it said is, we take most insurances. And I thought to myself, why are they asking about insurance if it's free? And I can see a person being very discouraged at that moment. And they already mistrust the system. They said it was free, and all of a sudden they're asking about insurance. And people don't want to be shamed if they don't have insurance. Or people don't want to pay for a vaccine that somebody says is free. So the consistent messaging is incredibly important in getting more people to get vaccinated.
Do we know why then people are being asked to provide their insurance, not just for the vaccine, but sometimes being tested as well? Do we know why they're being asked for insurance information if the vaccine is supposed to be free?
I think the message is tied to get people tested as well as to get people vaccinated are kind of becoming intertwined. Testing is not necessarily free. It can be free, but testing often tries out of pay pocket or your insurance can pay for it to be free. So I think in trying to kill two birds with one stone, they're eliminating one of the birds more often than not.
So for example, NOMI, which is a third-party vendor that the state has hired to provide vaccination and testing, they will ask for insurance even though the vaccine may be covered, but they want to bill insurance for testing. And that's how many of these third-party national companies are getting paid. They're often for profit, so they have to get paid somehow. So that's why if they're doing dual, if they're just only testing, but if they're doing testing and vaccination, they're going to ask that question, even though they can provide a free vaccine.
What should viewers know then if they're concerned about that part? Can they decline to provide their insurance information and still get the vaccine in that case?
Yes, they can.
Okay, that's
not required.
That's good to know. I also want to talk about one of these points that we have discussed before this segment is showing compassion and respect when doing intake questions. I don't think that people realize that is such an important aspect when we're trying to boost, right, this vaccine participation and whatnot. Can one of you talk about why we need to think about being more compassionate and respectful when it comes to these intake questions and how that can be discouraging to the Black and African American community?
I'll take this one, Sam. I think one example would be knowing what a chronic condition is, knowing if you're diabetic, if you're well controlled a lot. These are some of the questions. And then knowing your medications offhand. If you're someone that is maybe doesn't have the best health literacy, you have poor eyesight, or English is not your first language, you need help just trying to do this over the phone or on the website. And then you're gonna have to get somebody else that's hopefully home that can help you do this. That all should not be necessary to get the vaccine. All that sometimes really is most important is, have you had COVID before and have you had a recent monoclonal antibody infusion? But even that, is it particularly necessary? People can get the vaccine, and correct me if I'm wrong, Sam, within 2 weeks after having a COVID infection. So there's no 90 days or 60 days waiting period, which is a myth that even we as physicians put out and had people doing early on in the first and early second quarters. And some of us really need to be on the same page.
Yeah, I think this speaks to all human beings, not just African Americans, is that if you already have a mistrust for the system, the last thing you want is to feel judged when you go to the physician or you go to the medical facility. And they're asking you all these questions about, are you overweight and how much do you smoke and how much do you drink, which is irrelevant to getting the vaccination. You know, and I agree with what Dr. Ferguson said. You know, the two questions are, you had COVID recently? No, here's your shot, end of story. The rest of it is superfluous and unnecessary.
Yeah, that means so much, especially because some people might be in life-risking situations just because they don't want to feel shame for other conditions that they may be facing. Dr. Ferguson, we have about 30 seconds left. I want to know, what are you both doing with this information that we've discussed, and will we see some of these solutions implemented soon in our community?
I think the Utah coronavirus.gov, I think Utah itself does have the ear of the community. There are community leaders, particularly in Salt Lake County, that I work with regularly, Claudia Leoza and Kevin Wynn, particularly with Multicultural Affairs Division with the state. We are actively working behind the scenes to try to do more events, more mass campaigns, and to increase appropriate messaging. Sam?
Well, I mean, one of the top ways you can get a hesitant person to get vaccinated is having it directly come from a doctor that they trust. So every patient that I see in my clinics or in the hospital, I tell them, you know, if you trust me to take the brain tumor out of your child's brain, you should trust me when I say you should get the vaccine as well.
All right, we've been hearing from Dr. Richard Ferguson and Dr. Samuel Cheshire, both amazing individuals helping us improve these vaccination rates in our community. Thank you so much for both joining us tonight to share what you know about this issue.
Thank you for having us here.
Thank you.
We'll be right back.